Welcome, everyone. Thank you for coming. We have the 11:30 start time so that folks can get their lunch and eat it before we get started with our panel. So you're not worried about. And if you just got your lunch, no worries. You can just make noise. We'll be making noise. You can be making noise. My name is Leah Wen, and I'm the program manager for the UW Consortium for Global Mental Health. And today I'm going to play a little bit more of a role than I usually do in our presentations. I'm going to be facilitating the panel also. Yeah, I'm just really grateful to have our panelists here today. I'm going to start on the left here. Well, yeah, you're left too. Okay, great. Haneen Shibli is a Fulbright scholar at UW, and I'm going to let everybody introduce themselves more fully. But I just want you to know their names. And then Lamont Tanksley next to her is a peer support specialist. Is that right? Did I get that right? Great. At the VA Seattle and Puget Sound. So did I get that right? Totally. Enough. Yeah. And then we have Jacob Bentley, who's a faculty member at UW and works at UW Medicine in the Department of Rehabilitation Psychology.
Medicine, yeah.
Rehabilitation Medicine. Thank you. I didn't make my little cheat sheet for my intro, so great. Just off the cuff here right now. Kate Hoester is I've also both a UW faculty and at the VA. Seattle Puget Sound and is a psychologist there. So we're really grateful to have this awesome panel of experts with us today. They all work in the area of trauma rehabilitation and work in partnership with community. So we're really excited to have them. I'm going to advance and do a little land acknowledgement if I can get my slides to advance. There we go. There. Great. So University of Washington acknowledges the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Suquamish, Tulalip, and Muckleshoot nations. And I acknowledge my connection to this place that is made possible by the Indigenous people who love and care for these lands and waters and have done so for millennia. I specifically thank the Achuapsh, the people of the Achu or Lake Washington, the lake that brings me solace and guidance. So today we are going to do, the panelists are going to introduce themselves a little bit more fully. Then we're going to have an intro to PTSD and recovery with some slides, and then we'll have some examples of community partnerships, and then a discussion with our panel, and then you'll have a chance to ask the panel questions as well at the end. Right. So we'll go back to our first slide and just let you introduce yourselves.
Yeah, I can start. Hi all. My name is Haneen Shibli, and I've been working with the Islamic Trauma Healing Project with Professor Laurie Zollner. I'm a Fulbright scholar, postdoc. My background is actually public health. I think public health and psychology overlap, and my work is actually have been through my PhD journey in Israel among the Arab minority in Israel and the marginalized communities in terms of access to health, mental health, and physical health. And when I came here, I said, okay, I want to work with the marginalized communities too, but I want to expand my expertise and maybe look at mental health, because mental health is a huge issue among the Arab community in Israel. And then I collaborated with Dr. Bentley from there. And my Fulbright is going to end in 10 days. So it's a kind of my goodbye and the last panel here.
And Haneen was with us in October and gave our kickoff speakers event in October. So we're grateful to have you back. I didn't know it was so close to your end.
Yeah. Thank you,
Leah.
Leah.
Lamont Tanksley. I think thinking of introducing myself, thinking about community, it brings in the fact that I am a veteran, and like many veterans, we joined the service very young. I joined at 17, to boot camp at 17. And so there you do not get to establish yourself as adults in the community. And so you may be lacking what community is when you travel from place to place in a military setting, considering that the US has been at war actively for about 20 years, and where you're coming in and out. So working with bringing community to my fellow veterans is very important to me, as many veterans do not go back to the location that they started this journey in. And so having gone through the military, got a degree in criminal justice, really thinking about social justice, later getting a degree in psychology, working, retired, being blessed with having enough income to then later choose a job where I could give up a job at JBLM, supervising 30, 40 employees on a daily basis, and do something that was much more meaningful to me, which is peer support, helping veterans find a level of self-care and finding different ways to bring therapy and recovery and wellness to themselves, both inside and outside traditional means.
My name is Jacob Bentley. I'm a psychologist by training. I'm an associate professor here at the University of Washington in the School of Medicine. As Leah mentioned, I work at Harborview on the Regional Burns Center there in terms of my clinical effort. And I'm there about half of my time doing trauma-related injury recovery work, and we do have a peer support program as part of the Burns Center as well. And so maybe there's some aspects of that injury and recovery and lived experience expertise that we can speak to here to the extent that it would be interesting to folks. The main focus, I think, of my contribution today in collaboration with Haneen is to share a little bit about some work that we've been doing in collaboration with the local Afghan community. I've been really fortunate for about the last 20 years to work with various refugee communities in the Seattle area in different capacities. And over the last 3 years, we've been able to co-develop, adapt, implement a faith-based PTSD and trauma healing focused project in the Afghan community. So we'll share a little bit about that, and happy to talk about some of the cross-cutting themes that really emerge in that work across the different kinds of populations that we might be seeking to serve. So thanks for letting me join the conversation.
Hi, everyone. I'm Kate Hoester, and I am a clinical psychologist at the Seattle VA. And I also am associate professor in the Department of Psychiatry and Behavioral Sciences. And clinically, I work in the PTSD outpatient clinic along with Lamont Tanksley. I've been at the VA for 15 and a half years and lead, traditional evidence-based psychotherapy there. But what brings me here to this conversation is all of the great work I've gotten to do in collaboration with Lamont, working together to co-design and test interventions focused on finding recovery from PTSD through health behavior change. I also have partnered with Lamont on some collective advocacy work that we've done with veterans to advocate for national policy changes in how the VA addresses and can improve healthcare for Black veterans. And so we can speak to both of those today. I'm really happy to be here with you all. And I think I'm going to provide the orientation to our presentation or panel today. We thought that it would be helpful to start out with some basics about what PTSD is and how it's treated in traditional settings, or in our healthcare system. Evidence, the DSM-5 has criteria that must be met to receive a formal diagnosis of PTSD. You have to have experienced trauma and then be experiencing symptoms in each of those categories. So re-experiencing the event, so having things like nightmares, memories about the event that are intrusive for you and upsetting to you. Avoidance is the sort of cornerstone of PTSD. So avoiding being reminded of the event, it's really the glue that keeps PTSD together. And we'll talk about how that's addressed in treatment. So avoiding, understandably, right, really naturally thinking about and re-experiencing the event. Alterations in beliefs and feelings. This is a newer addition with the new DSM, but acknowledging that experiencing trauma changes the way you think, right, about the world, yourself, and other people. Seeing the world as a dangerous place, for example. And then having hyperactivity, hyperarousal, so disturbances in sleep and attention and so forth. And the symptoms have to be functionally impairing for at least a month. What I do want to acknowledge is that, you know, I think all of our perspectives at this table is that while this is the, you know, these are the criteria for getting a PTSD diagnosis, it can look so different for so many different people. And the thing that we all attend to in our work is what's the functional impact on you and how can you be how can you live a full life with trauma and your experience of trauma as part of your life. And so while PTSD treatments importantly target these symptoms, they also are all focused, if in an ideal world, on improving functioning, getting the most out of life. And that's where we're going to be speaking to today. So next slide. One thing that we wanted to highlight is that the prevalence of PTSD really varies by population. On the whole, in the general population, prevalence is about 6 to 12%. There are some subgroups that have higher prevalence, like veterans. That's why it's such a focus of VA care. One thing we wanted to highlight is that the vast majority of people who experience trauma do not go on to develop full clinical PTSD. And there are various reasons that that's the case, some resilience factors and so forth. But that doesn't mean that trauma isn't impacting folks who don't develop PTSD. It might result in other clinical presentations like depression or impact functioning, but not meet that sort of threshold for PTSD diagnosis. And so we'll be attending to those folks as well as we're talking today. Okay, next slide. We wanted to highlight that there are several evidence-based treatments that are really emphasized by systems like the VA, where treatments like cognitive processing therapy, prolonged exposure, and EMDR are sort of the three psychotherapies that have been tested the most, so they have the most evidence behind them. And in each of those cases, really what you're trying to do with someone who's experiencing PTSD is have them base, accept, and integrate having experienced trauma and then carry that with them and live a full life, right? That's the ultimate goal of these treatments. And there are lots of additional psychotherapies that do these things. So I just want to acknowledge these are packaged treatments that are testable, right? And I deliver them myself because I have seen them work for folks. There are some medications as well that have some evidence, but the first line treatment is psychotherapy. One of the things to acknowledge is that a lot of there's really high dropout in these treatments. For many folks, they don't complete the full course. So while they may be effective, it's certainly important to fully engage in them to get the benefit, and many people don't. And so we're left with a need to continue trying to find treatments that are suitable for folks and that really help people fully reintegrate into their lives. So with that, we're going to talk about the recovery model.
Yeah, thanks, Kate. So I appreciate the backdrop that we're all approaching this conversation from, not from a real functionally focused perspective, in understanding the post-traumatic distress that the populations often experience is important to account for when we're thinking about solutions, including the clinical kinds of interventions that you mentioned, but we also know that there's a high degree of resilience. There are many resilience factors that can be amplified within community settings, and that often healing happens outside of clinical structures or hospital systems. And so I think part of our focus today is really trying to imagine and give some examples from different ongoing work about where interventions are located, how they're packaged, maybe how they are delivered in ways that's acceptable, and and really approachable by many different populations. So we want to share a little bit about this recovery model called the CHIME model. And this is from the broader mental health literature, but applicable to PTSD and post-traumatic recovery. And CHIME stands for connectedness, hope, identity, meaning in life, and empowerment. And just to speak about each one of those briefly, because I think each one of these themes really come through in the work that we'll be sharing about, that we know that connection is important for healing, and connection to others, to trusted others within a community setting, feeling supported by other people, feeling understood, and often that sense of belongingness may occur in structures outside the health system or adjacent to the health system, or in home community settings. And so really attending to that as we're building out meaningful post-traumatic interventions, I think is important. The sense of hope, and I think that gets back to something that Kate was mentioning earlier, that trauma is really widespread in terms of exposures across our global population. And that people are so resilient, even after repeated exposures. And so trying to understand what that resilience is all about. I think we're still in a very formative time from a kind of scientific perspective and understanding what resilience really represents, but accentuating that sense of hope for recovery in the future. The identity piece really brings into focus different intersecting identities that people may hold, and that may make them susceptible to repeated trauma exposures, or subject to additional barriers in recovery. And understanding those factors is also really important, because it gives us some window into how can we develop and implement those most effective interventions in a way that'll be, again, acceptable and approachable for those community members. The meaning in life piece gets at something that was sort of underlying a lot of what Kate was talking about in terms of the features of PTSD, but also the interventions, and that is trauma often affects people's beliefs about themselves, the world, and other people. And that meaning making is really central to the healing process. And so how can we go about engaging community stakeholders to evaluate the meaning that's made after a trauma within individuals and across communities, taking into account things like historical or intergenerational trauma, for example, and start to interact with those meanings, and hopefully develop some healing out of that. And then the empowerment piece, where does the locus of control reside when it comes to trauma-related healing? Does it reside in the psychologist's office? Does it reside in the healthcare system? Or is it placed somewhere else? And the answer to that is probably multifactorial. It probably resides in many different places, or at least has the potential to. But thinking critically through that, who are the agents of change? And where does the kind of active ingredients or the active agents in an intervention actually take hold, and how can we amplify those? I personally like the CHIME model because it's person-centered. It takes a multidimensional approach, and it's recovery focused. And I think many of those elements will come through in our conversations afternoon. So I want to share an example from our work in the African community, just to set a certain stage. And I know Kate and Lamont will share from their own work as well. And I want to acknowledge at the beginning here that in doing so, I'm doing so in collaboration with Haneen, and so feel free to chime in here as well. But also many other stakeholders who are not in the room, and I just want to acknowledge that from the very beginning. But this is a partnership with the local African community. This is work that was funded by King County. And it's an adaptation of a community-based intervention that was initially co-developed with the local Somali community here in the Seattle area. And This intervention is called Islamic trauma healing, and it was developed because community had, from the Somali communities specifically here, realized the effects of trauma in the community. They also realized multiple barriers, including stigma within the community around mental health concerns, barriers related to accessing mental health services in a westernized healthcare system, where individual psychotherapy, for example, just doesn't resonate naturally. And so really having to think creatively about what healing should look like and what the format of that is. And so the formative work around all of this started from that perspective. And it's intended to be a real integration of community wisdom and those evidence-based approaches to psychotherapy, specifically exposure-based therapies. And so this is a prolonged exposure-based intervention that tries to help people approach those post-traumatic avoidance through a natural exposure to distressing events. And that's not through prayer in this particular program. And then also restructuring those negative beliefs about the self, the world, and other people through readings of the Quran, prophet stories from the Quran that often represent what it means to be a displaced person, to be subjected to trauma, and then to find peace, comfort, and healing on the other side of that. This is a 6-session group-based intervention that's led by members of the community in accordance with kind of community norms. Men's and women's groups are held separately. No one is asked to share about their own trauma experiences within groups, so as to not re-traumatize other people. And it's manualized. And so the members of the community who are leading the groups have built-in structure that they're working from with that. You can see some of the feedback that we've gotten from our local Afghan community members here about the program. We just completed a feasibility study of this. We have some really promising results we won't share here today, but very encouraging that this is actually reducing distress in the community, and hope to see that grow in the future. Next slide, please. So this is we can sit down to one. Okay, that's good. So at this point, I'll stop there with this Lamont Tanksley healing program. Happy to share more about that. There's lots of nuance there, but at this point, I'll transition over to Kate and Lamont to share about their community partnership. Sure.
Right. So this was a research project that Kate and I did together, mostly centered around weight loss, but weight loss specifically for veterans who had PTSD, realizing how trauma creeps in and affects every area of life. I think the unwritten things that were part of this that helped the veterans was to see the small things that might be affected by trauma that rises to the level of PTSD. This was started off as a hybrid in-person and telehealth, which later moved to completely in-person and then later to completely telehealth. So we got to learn quite a bit from the different modalities, how we delivered it, what to include and to take out, by learning from one another as researchers and from the participants of what worked, bringing in a dietitian, bringing in 2 providers. It was a good thing to have multidisciplinary. We had a psychologist and a peer. Additionally, I think the fact of looking at other factors, me being a Black male, me being a veteran, and then the co-provider was a female. So we got to see a lot of different things to role model recovery, to bring in the fact that one of the facilitators has a diagnosis of PTSD, and over 16 weeks, clearly telling the veterans to bring in their stories and to learn while we're working out of a manualized research model and what we're delivering to them. And then adding things that this traditional program did not have. outside of just addressing PTSD and how it can affect your functioning in the community around weight loss. We also brought in the fact that there's behavioral activation, there's socialization, fighting loneliness, depression, and getting that opportunity to be out. If you're familiar with the veteran population, while the active duty population is on average 27, the retirees, the veterans, not all retirees, the veterans that we see at the VA on a normal basis are usually somewhere around my age and closer to 60 than 27. And so sometimes when we're thinking about what Kate said to begin with, that avoidance is the glue that holds PTSD together. This may have been their only time leaving their home to come to the VA. This may have been their only interaction with someone outside of the home. And we know over 50 million Americans live alone, and a lot of those are veterans. So this was a great social experience and we gave them touch points to see how community electronically, physically, emotionally, and in person. And even we would stress the use of their animals and the environment as thinking of that as community.
Thank you, Lamont, for introducing our intervention. So as Lamont said, we piloted the intervention. This was now, well, it was before the pandemic and about 6 years ago. And you can see some quotes from folks on the slide about some of the benefits that people experienced. And you can, I think, really see that the emphasis on community reintegration, that was part of it. So for example, engaging in community-based physical activity with other veterans, for example, being a component of the intervention. That in addition to the sort of, symptom reductions and health behavior changes, that people felt more alive in their lives and more connected to others. And so we went on to write a grant to test the intervention in a large randomized controlled trial. And we're collecting our final 2 follow-up outcomes this month after a 4-year trial. So we don't have the results yet from that trial, but we've been testing it, and Lamont we've been working on this for now over 10 years. So we'll see what we find with our trial. But regardless, I think from the qualitative input we've gotten from folks and just from the facilitators, that it's a really meaningful way to support veterans, to support each other. The other thing I wanted to highlight, which aligns with what Jacob was saying, is that our interventions at the VA are often group-based rather than in individual psychotherapy. And that was certainly the case with this intervention. And that is another way of just solidifying the power that can come in connected activity. So our cognitive processing therapy treatment, for example, is often delivered in a group. And we have seen through this program just how powerful that is in veterans supporting each other in that way.
Okay, I think Jacob covered almost everything regarding the ITH project. It was part of the ITH project since March 2024. And when I joined the project, my main role was to monitor and make sure the data collection and the monitoring of the eligibility of the participants, if they are eligible enough to be participate in the intervention itself, and if they have trauma exposure according to the questionnaires we were distributing among the community. One thing that they made mention when Jacob said that we did the groups of women and men separately, it was also led by the same gender of trainers. It was so important to allow the participants to express themselves without any obstacles and any barriers, especially gender barriers, and to make the intervention itself much more accessible for them. The whole project was in the mosque, so it's also something that we bring in the this program, this project, to make it more accessible to the community. And Jacob mentioned that it's sometimes outside the hospital walls and outside university walls and research centers. So bringing that to the community allow us as a researcher also to engage with the community and build the trust. And I assume we will touch that in the questions and talk more about that. The feedback from the community, we did a mixed method research, so we got a positive feedback from most of the participants, both male and women, male and female, sorry. And the key themes that emerged from their feedback was categorized to 3 themes, and it was emotional support, the spiritual growth, and the demand of expanding this project. And that was so great to hear that that feedback from the participant themselves, and have it like in front of us in words and quotes.
Thanks so much, all of you, for sharing the projects that you've worked on in community. And I think we heard a lot about what community brings to trauma healing, but I'm wondering if you want to kind of, I don't outline like maybe some specific examples that you feel like are really important that stand out in your mind from work in the community. And then if there's any sort of theory that you feel like holds that together about why, I mean, I think you shared it with Chimes a little bit, but what's the mechanism really that feels like it's at play here that makes community so important in trauma healing? Whoever wants to say.
I think one of the key elements is that you don't live at the hospital, you don't live at the clinic. And we think of these traditional sayings like, it takes a village to raise a child. Well, that extends on to the rest of your life, that we absolutely need one another. I think about with the population I serve for veterans, we are ingrained to that we need one another. You have this buddy check, you're always supposed to have a battle buddy and so forth and so on. And so I mention that all the time to them about needing one another and how it enriches life, even down to where Winston Churchill said, you know, they're thinking about this battle to regain their health, their recovery. And I say, yeah, going to war is hell. Going to war alone is worse. And so they buy into needing one another and then extending that to say, well, aren't you more than just a veteran? What else are you? And so let's get some of those demographics to help you too.
Yeah, I think just reflecting on what you're saying, Lamont, too, and going back to something that Kate mentioned earlier, is the focus on function, you know, that we're not here just to reduce people's distress, you know, that's important. But it comes down to how are people able to engage in meaningful life, and what does that look like? And so much of the knowledge and expertise and wisdom for that comes from the community, and it doesn't sit within the hospital structures or the clinic structures. There might be tools there within the health system or in other places, but ultimately life is lived elsewhere. And so being able to locate the work there, and then also to understand, I think there's a lot of room left to learn here about what function means to different populations, and what does that even look like? How do we measure that? How do we understand that? And what are the variances in that, you know, across different cultural groups, and so I just think there's a lot of constructive work up front that is so essential in doing this, where it is it's to our detriment to approach a project with a formula in mind at the beginning. We might have guiding theory or guiding principles, but if we think we know what the end result is already, then we foreclose other possibilities. And I think that's one thing that I really enjoy about community engaged work, is that it's co-development, you know, and it's trying to understand different ways of knowing. And so for our work, yeah, you know, in terms of specific examples, we've sat down from the very beginning with and did a stakeholder analysis to understand like, who are the people who are going to be engaged in this work and what are their perspectives on it, and what are the questions to ask and what are we not asking, and what are your priorities? I mean, that's the starting place, and then everything gets built from there, as opposed to having a built structure that everything else gets shoved into.
Thank you both for that. I was going to say, you asked about a theory that underlies, and I think just if you like the cognitive behavior theory of that underlies most evidence-based psychotherapies, just to get down to that level. If you are, and the theories underlying exposure therapy for PTSD, that essentially, you want, and in the anxiety disorder, not just PTSD, the idea is you expose yourself to the experience that is feared, and over time you adapt, your body adapts, you learn new information that helps you not fear the thing so much. And that can work sometimes for many people. And so if you think about community engagement as a priority functionally, it also serves really, really well because it's usually something meaningful to the person who's getting the treatment. So say they want to increase their physical activity, we're encouraging them to go out into the world and do that. That is also a form of exposure therapy for many people. So not only are they getting exercise, which matters to them personally, they also are then acclimating to the experience of anxiety in their body and learning, hey, danger maybe isn't around every corner. Maybe it is okay for me to be out in my neighborhood and talk to my neighbors, et cetera. And then that learning can then propel that person further and further in their treatment recovery or their PTSD recovery.
Yeah, and also the thing that the community is active through the whole process of having the intervention, having the study, and it's so important. I would like to bring just a specific example of the methodology that we have been doing in this study. So there were 3 time points collecting data, and the first time point we created the questionnaires in their language, which is the language of the participants, to make it accessible for them. But we knew and assumed that some of the participants may do not even read and write in Dari, and not talking about English, it's also their mother tongue language. So we assumed maybe having the questionnaires in the form of paper like handwriting and answering with paper print questionnaires. And the other form was the online questionnaires through Qualtrics and distributing this via their phones, and they could answer that. And we assumed that maybe with the paper print it could be work much more better. And surprisingly, we realized that with the online links, it works much more better, and they were able also to script logic the questions and answer the questions much more better. And the data was not a mess compared to the one with the paper print. So listening to the people needs and the participants and knew that they were preferring form of something that is happening through the research, make us realize, okay, so we go with that one. And I think it's a lesson to hear what the participants or like what the community needs in terms of the research itself, but also the intervention and the program itself.
Are there characteristics to communities that make them particularly helpful in trauma healing? Are there, I mean, I think we got at some of the examples, what's happened and the mechanisms, but is there, when you think about communities where trauma healing has taken place, what are the characteristics of a really particularly healthy trauma healing community? Anyone start with that?
Buy-in and obviously marketing, that there's multifaceted types of things to engage in. Like Seattle has a flashcard that's specifically provided to citizens who are going through mental illnesses or other disabilities, and they can get this card. It stands for Fun, Leisure, Activity, Savings, and Health. This is directly given to citizens who have a disability, because we say we understand the benefit of being able to have fun and leisure in our community as a means of combating your mental and physical disabilities and have you engage fully in the community with the rest of the population. And so having those different programs and having them function and not focus on one area or just one item. And then having these community partners willing to have handshaking routines across organizations.
What do you mean by handshaking routines?
The ability to work on is a programming term. Yeah, just willing to work with one another. No one wants to hold the keys to the car and say, this is me. I won't refer to you because I'm trying to soak up all the dollars. Is it to work on the dysfunction, or is it to work together on the dysfunction? So you're not just saying, this is my one goal and I'm gonna focus on that irregardless of, sometimes I talked about having co-facilitators, where you were talking about having culturally specific information there, and you're talking about different language, but saying, how do we try to add that to as much to every program? But then also realizing we can't be all things to everyone, so being willing to pass the baton to another organization.
Yeah, just piggybacking on what Lamont said, I think is really important. And I hadn't thought of it until you said this, as what a healthy community characteristic might be, but having institutions and governments in your community that support programs, support healing, and support something like the flashcard. Even just down to like, what is the structure of the built environment in your community? Walking here from the light rail, I don't come to campus much, but I was like, oh my gosh, there's a protected pedestrian pathway, and I was filled with glee. But just thinking about structures like that facilitate even, when we're talking about these interventions that Lamont and I are doing that involve walking in the community. So many communities around our country don't even have sidewalks anywhere in their city or town, don't have, protection for pedestrians or cyclists or people with disabilities that are trying to get around. And so, thinking about to the very highest level of, government and institutional support, we need healthy institutions to create the conditions of resilience in a lot of cases. It's at least one component I think that needs to be there.
Just quickly, just sidewalks. I live in Bremerton, and I'm like, still the talk of the town is like, in the area where I live at, we got real sidewalks like 3 years ago. We're still marveling about that.
Yeah, I think I appreciate so much what people are mentioning, in this in the social environment, in the built environment, that are either enabling or disabling for people's access to different resources, and the ability to access resources also obviously not uniform across all different communities. And so I think one of the things that communities bring, in addition to the internal insider knowledge that is so essential, is an often unspoken mapping of where the fault lines are around needed services and where the gaps might be, and an outside perspective might look at it and say, oh, there's these different areas where we got to be attentive to, but that's going to be a hopelessly incomplete picture, and the community has the realistic, practical knowledge of all of those things, in addition to some real creative thinking about solutions as well. And I was thinking about what Kate had mentioned in response to the question before about sort of taking from our approach as psychologists, a cognitive behavioral conceptual frame or some other kind of theoretical frame. I think that there's a lot of power for those academic community partnerships that leverage that kind of expertise, but kind of package those evidence-based principles in collaboration with community partners in a way that will be approachable for those communities, taking into account those fault lines that only the community often appreciates and knows about. And so I think there's a lot of opportunity to just build more programs that way.
Don't have much to add, maybe just the trust thing, like it's so important to have this characteristic of building the trust with the community that we work with. And by showing them, as a researcher, we do not come to the mass and just collect the data and just say bye. We try to make it access to them in terms of language or culture or gender accessibility. And this is showing like we have an aim to build the trust with the community.
Thanks so much. So my next question is about sort of adaptation of traditional trauma healing modalities, cultural adaptation and adaptation to context. I think you have both both examples in the community have given really great examples of how you've done some of that, and listening to the adaptations made for the Afghan community and the Somali community before that, using prayer, not sharing, like using prayer to reflect on the traumatic experience, and then using sort of examples of to change the thinking from the Quran, brought some tears for me. Or just like it's just so beautiful to use the tools that are existing and to figure out what that component is. I mean, I'm talking too much here, but I think the component that comes from sort of the intervention, what's the key component that's important, and how do you match that to the existing strengths of the community? So I guess I'd love to hear more about other examples of that you've from either other projects or more depth about how that came about, or just more about those adaptations. It's really lovely.
It seemed like you were talking to me.
No, I don't want to.
I think that I think there's a lot of examples of this kind of work actually that happen, and it often happens in conjunction with peer programming, because anytime you are there's an intent to develop something that is community driven or peer based, it's a recognition that something else is needed, that the knowledge base is incomplete, that something about treatment as usual isn't working, and it could be not working for any number of different reasons. High dropout rates on treatments that we know work if people are able to stay engaged, but also people live complicated lives, and it's not always easy to stay engaged with those things. And so from our example with Islamic trauma healing, I think what has helped with that is in the sort of development of the content of that work is that it started from the community perspective. There was an identified set of problems in need, and a motivation to approach that, and then a real willingness to sort of put together different kinds of perspectives to try to address the issue. And I suspect it's similar is true in your work with veterans as well. And so I don't know if I have other good examples except to say that through in the burn center, where we have people who have often pretty extensive traumatic burn injuries that create a sense of kind of being othered by mainstream society, or maybe that's not the right term, but that that those peer programs help our patients to break through things like concerns about their body image, concerns about how they'll be received by other people, and those are kinds of concerns that that we address clinically through our health system. But really where we see people start to change is when they're able to engage with other people who've lived that experience and walked that path and found some success on the other side of it. So other examples from your work at the VA that you want to share?
I'll just add that I joked earlier that we've been, developing this intervention for over a decade and testing it and so forth. But I think what that highlights is all the patience and listening and adapting and integrating the feedback from veterans, and then also co-creating this intervention together. I mean, that takes it takes time, right? It takes actual authentic listening and being flexible and trying to meet the need. And so I think that the key being, really hearing folks and recognizing there are many experts at the table in that. The other thing I wanted to highlight is that Lamont and I recently conducted a photo voice project over the course of 6 months. We recently published a paper on this. It's in JHM if you want to read about it. But we worked, Lamont and Michelle Borowitz is another Black psychologist who used to work at the VA, co-facilitated 6 photo voice sessions consecutively with with Black veterans to elicit their input about what could improve VA weight management care and VA care in general. The veterans in their group provided photos to represent their daily lived experience. And then, with photo voice, it's a community-based participatory research method in many instances, is not only a data collection tool, but it's a capacity building and leadership development tool. And so at least one veteran from that project is now our collaborator and is going to be presenting with us at an academic conference in a few weeks, and has a seat at the table at the national level to influence healthcare delivery. And so, I just want to give kudos to Lamont, who did an extraordinary job of facilitating those groups and creating a trusting space for veterans to really identify the problems with our care and improve it. And the VA is already making changes at the national level for how weight management and care is delivered based on that input. So that's another example.
So that's what I would have spoken about, saying you're all future researchers, right?
Or current.
Or current. And so one of the things that was very important to me about the Move by Love project was to look at this from many, many different aspects. And one of the first things I advocated, Michelle, who is no longer at the VA, she's a Black female, and we were collecting data on Black veterans. And it doesn't matter if it was Black or anything, it's just connectivity of where you're getting your data from and how. And we said, how about looking at both sides of the research? Not just the participants, but also the researchers, the primary interveners, how we're looking at the data, who's helping to break it down, because of those experiences that, as Kay said, different experts at the table and what they each bring that we may not even know. And so when we were talking about who would be the primary interveners, and I say, it might be pretty good to have, we're asking these Black veterans, how do we make things better for you? And you have a white person asking, and they're seeing this and that, and they have to trust you to bring your story back. And with the proliferation of information now, people will be very present, seeing part of it, the way they wish to tell their story. It really behooves us to look at all sides of how we build research studies and research teams. And that way, they are more collaborative when you're talking about approaching people in their own language. Well, is it someone that can barely speak it? Is it someone who seems like
are you doing this? Are you gonna build the right rapport with me? Because we see, particularly in qualitative research, we may not get the best information back based on what the participants think of the research and whom they're speaking to.
Those are great points. Thank you all. I'm wondering, so we talked a lot about community. I'm wondering if there feels like there's any parts of trauma healing that are particularly that are best done in private session. Like if there's and what feels like it's important, just on the flip side of that coin, what feels like it's important to be done individually.
I will leave the answer for the clinician.
I wouldn't want to be making that decision. What we do is offer to patients to determine what they want to do. And so there are groups at the VA, for example, where people share their traumatic experiences in a group and provide support to each other. And then some veterans ask for an individual session to do that or two, and that's what we facilitate. So I think it's just really important that the system provides opportunities to do it in the way that is best for and that the veteran or patient prefers.
Yeah, I don't have anything to add there, except I think there's a piece that you were just speaking to, that you were speaking to, Kate, a few minutes ago, also around just the slow nature of understanding and developing that understanding. And I think there's one of my worries is that we're really vulnerable to systems pressure to do things fast and to do things incompletely or in half measures. And I'm speaking specifically on the academic side of things, right, where in writing a grant, you have to frame something a certain way in order to get it funded. And the locus of power and control there is positioned in a certain direction in that regard. And so to do the kind of work I think that we're talking about is really challenging because it does happen slowly. And sometimes we're fortunate to get funding in order to be able to do that. But oftentimes we're not. And so and that flows into pieces like your question around, is the intervention individual as a group, and how does that work? Because in order to understand some of the answers to that question in a given population in a certain circumstance, it takes time to understand it. We often don't have that time.
Thanks so much. I'm wondering if there's any emerging themes that are sort of like the forefront of this work, any from sort of a conceptual standpoint, measurement, or a practice perspective, things that feel like they're coming, what's next?
Thinking about the answer. I have some. Oh, good.
As far as dealing with trauma in the community, I think there is a lot more acceptance in CIH models of saying
See what that is.
comprehensive and integrated healthcare that's away from Western, as we go ahead and accept and create different ways to treat trauma, to think about what is therapy or what is a complement to therapy. I happily tell the veterans I work with, not a therapist, don't want to be one. I'm just here to try to make whatever you get from therapy better, whatever you want in your life. I mean, when I first got to the VA, I was very resistant to seeing the guy that helps the people do the arts and crafts. I was very consistent in thinking that this is not what I wanted to be thought of as my role or for this discipline as a peer support. Saying what we have to offer is a lot more. I had to grow in that and hopefully grew with the veterans, being able to come in and seeing what they wanted, what they needed, how we could complement care. So saying what was next of saying, Well, in the role as Washington State changes the role, the training for peer supports and more organizations bringing them on. We now have peer counselors and peer supports and saying, how do you integrate this discipline into the work you do? And saying, take those experts at the tables and say, how do you get in where you fit in? What is your role here? And I think that's still growing for peers, but also as a peer, being able to figure out roles in the community with people that you're working with directly in a patient care setting. I take a lot of veterans and we do things out in the community and figuring out, do you always meet in the community? Do you meet here? Do you meet there? What's the safe way to do it? What's being able, is it okay? Some veterans, we were talking with some peers and they said they don't want to put some of their social groups into the veterans record. And then there's the concept of, well, do you need workload credit? And what's the barrier to the veterans wanting it to be in the record or what's not? And being able to explain what's the benefit of it. So when I think about what's next, it's starting to say across different disciplines, different clinics, quantify each other's work to believe in one another and continuing to work together in a whole health manner. When a veteran shares with me that she wants to go see her mother and the reason why, how can I help that with a nurse who's helping her to lose weight? With a dietitian who might tell her how to tell her mom about, you can't just shove food at me every day because you're glad that I'm home. And she's also nervous about some other things. And someone said, well, why are you calling me to talk to me about that? And so I think community is not just outside the clinic, but community within clinics and hospitals, and that community between consumer and provider, and that we all realize that we're all part of that, and making that definition as strong as possible and complete as possible.
Fine.
I'm sorry.
Yeah, what's old is new again. I was just thinking as you were talking a lot about how medical anthropologists for decades at this point have been talking about explanatory models of illness and meaning different the lenses through which people view their own health and view the world around them are informed by so many different factors, and all of those factors influence the presentation of a health concern, the interpretation of it, and then the functional implications of it. And specifically in cross-cultural global mental health research, there's still an immense amount of work to do to really understand kind of what that means and how that plays out in the work that's being done. And often the assumptions from a measurement perspective, from a conceptual perspective, are still based and rooted in a Western DSM defined billable taxonomy that doesn't necessarily represent the interests or the needs and benefits of the key stakeholders there, from all different angles, as you're mentioning, Lamont, from the healthcare provider, healthcare consumer, because we're all both, and all of those things. And so I think there's just a lot of work to do to understand what are the constructs that we're focusing on. How do all the stakeholders think about those constructs? How do we then measure those things from a research perspective to develop an evidence base? And then to your point also, Lamont, who is interpreting that data and providing the meaning-making messages from it? And so I just think the whole field is still in front of us to do all of that, which is probably a broad answer, but I think true.
Oh, yeah.
So what's next? I would think maybe keeping in mind all the time and taking into consideration the social determinants of health and the environment of the patient or the participants in the research, what's going around, and not just focusing on the trauma itself, but also what's leading to the trauma and what are the conditions right now. So just an example, if you have a plant at your house and you planted mint, for example, and then the mint is dying slowly, you're not asking yourself why the mint is dying. You ask yourself what's happening in the environment of this mint and what's leading this situation, what's like the reason that are leading to this situation. So also the maybe policy makers and the healthcare providers, when they look at the community, maybe we should not take into granted that the community itself is just one community, because one size not fits all. And we need to look also at subgroups, like we did here in the ITH. We look at separately at the group, female groups and the male groups, to look on people like refugees who came just recently, or like refugees who came 3-4 years before. So it's like those kind of things that need to be more highlighted and emphasized. Yeah.
Well, I am so inspired to hear all of these future directions. I think there's a lot that's coming to mind for me right now. I think though, like I want to highlight an example that I saw this week at the VA. I walked into the facility and saw this whiteboard with a sign with handwriting on it, and I could tell it was Lamont's handwriting because I've seen it a lot over the years. But inviting veterans to join in a walk from the VA facility on Beacon Hill along the Chief South Trail. And then I saw a veteran come up with, a mobility facilitating device and, read the sign and take a picture of it, like an older veteran. And just realize in that moment, like the way that sort of breaking out of our traditional barriers of how we deliver healthcare and like connecting physically through activities like that, through outreach like that is so powerful. And I don't know if it's the future, but I hope so. I hope that we do more of that as a healthcare system and as a society of just going on a walk together and talking and see what emerges from that. So.
It's a great walk, 3 miles, 18 veterans.
Yes. What was that?
So we call it a all hands hike. I like to pepper my interventions with some military speak. So military people all understand all hands, and so it really makes them connect with it. But it was 18 veterans, and the walk was 3 miles. And to see people with all different levels of mobility and being okay to be in their own individual pods, catching up with one another. And then, so that part of the community, and it ended up at the Jefferson Park Community Center. I think like 11 of them signed up for their Tai Chi class that they, so it was really good to talk about integrating the community, saying, where do you start? The veteran may not be willing to jump right into therapy, because we also do a poetry writing class as part of another intervention. And several of those veterans just said, wow, doing this and feeling okay writing a poem and reading it in group a couple times. I think I'm gonna ask my MHT treatment coordinator about that wet class thing that you were talking about, which is a certain type of exposure therapy. So I think that figuring out how to get starting points.
Yeah, that's really beautiful, having multiple ways in. Yeah, thank you for sharing those examples. I want to turn it over to the audience. If you have any questions. There's one there.
I'll 8 questions in the chat.
Oh, great, thank you. Perfect, thanks for pointing that out. Okay, For the Islamic trauma healing projects, what were some limitations or barriers with the Islamic adaptations? How were you able to navigate them? How were you able to get the community to engage?
Yeah, I think we have some barriers that came up in terms of like the access of the participants, in terms of timing, like when we did the intervention and the mosque, and if it was suitable for like moms, for example, to come into the mosque, especially for like be part of of the study and the intervention. I think maybe public transportation barrier that we face, that it's also kind of a physical access barriers. Can't like remember if we had like in the interventions of, so if you have something to add.
Stigma.
Yeah, oh, of course, yeah, stigma. We know that trauma perceptions and it's different across different groups. I also work with the Arab community in Israel. It's also common that mental health issues in general among marginalized communities or tight knit communities is like there's a stigma there, and we face this also in the ITH project. And
So were there ways that you were able to overcome any of those or address those barriers?
So one of the ways that we interacted with and try to address some of those barriers is we were fortunate actually. And some of it gets to the formative work that that we were talking about earlier. Really taking time to do an intentional stakeholder engagement, stakeholder mapping and engagement strategy at the beginning. And through that process, we were able to develop a close partnership with religious leaders, with an organization of Afghans in Washington State called Kabul, Washington, the Afghan Health Initiative. And we partnered closely with the primary mosque in Kent where the Afghan community congregates, and had a strong partnership with the imam, the lead imam there, who was actually one of our group leaders. And so having that buy-in, and one of the ways that would play out in terms of stigma intervention was that through the large Friday prayers, he would start to speak to some of the themes related to community trauma and healing, and the importance of gathering together and opening space for members of the community to not orient around some of these challenges from a sort of like mental health lens, but really more through a community lens and through a healing lens and through their faith perspective. And so I think all of that, and it took a few months of laying that groundwork and for some of those communications to take hold. And also just acknowledging that some of the barriers were even within the community differentially applied too. So women didn't have a formal space in the mosque, and so we had to really think about that and work with the mosque to problem solve that for when women could attend the mosque and what would be appropriate, and all of those kinds of things. And so there's some real practical problem solving also that had to go into all of that. It ended up being that I think 2/3 of our participants were women, and there was a real strong sense of engagement from the women, specifically seeing a need there. And so we adjusted schedules to after school drop-offs and pickups and those kinds of things so that women could access the program.
Have a question. Let's see. I think we have time for maybe one more question.
I have lots of questions. My work actually is the intersection between both of your work with veterans and refugees. So my quick question is that do you have your veteran group, do you have any unhoused veterans in your group? And if you do, how did you recruit them?
I'll take this opportunity to say that the VA nationally has an extraordinary program to address homelessness. There was recently a big feature about it in the New York Times. So there are many veterans experiencing homelessness who have participated in our program, and they tend to be housed in temporary or long-term housing through what's called HUD VASH. It's a collaboration with HUD by the VA, and it's been really, really successful. And Lamont and the other facilitator have done a great job of doing what we were just talking about with understanding that each person's individual housing environment really influences their access to activity and community engagement. And so just really listening and understanding the needs of the specific person, whether they're living in a retirement facility or a temporary housing situation. Some people have been living in vehicles as well, and we also take pride in our program. Being in VA, we're integrated with the whole healthcare system, so we can make facilitated connections with programs like HUD VASH if a need is identified. And so that's another way that has happened.
And the VASH stands for VA supported housing, but connections can be made in so many different ways in that a large population of the homeless have phones. And so we can have VA Video Connect and go through telehealth. They can also visit a VA center. And even though they may be homeless, the benefit of a in-person group is an hour or two outside of the elements in a situation where they may also be fed to interact and feed themselves with the community as well as possibly with food as well. But having those different ways, and we have had plenty of veterans who are homeless who have joined plenty programs and joining those different ways. But we also think of the Washington State definition of homeless, that a person may be supported in ways where they're not always or not completely living in a car or on the street, still identified as homeless and able to access care. Check about your program, the intersection, right?
Actually, I have a comment, I just want to say I really appreciate this panel. It's really speaks to me. My work kind of encompasses both of yours. About refugees, I am a former refugee. This would be my 45th year. In my experience working with my community, that's Vietnamese boat people, refugees, the first few years are actually the honeymoon. And then after that, things get harder. Because we're culturally displaced. We're not just displaced physically, we're culturally displaced. And so I really appreciate the connectedness and the identity part of childhood. That gets worse and worse as people live here longer and longer. And so there's still more work ahead. It's so I'm glad that they are getting this kind of intervention early on. Thank you
so much for sharing. Okay, if people aren't running off, then I have a hand back here, and then I'll. Are you guys okay for a couple more minutes?
I have a question. Are the services for the VAs only for those who left in good terms? I was trying to look for the word for when you are released from the army because like you did something bad. So yeah, for those people who did something bad and were released from the army, get access to these services.
So there is a certain amount of care you still can receive from the VA, MST, some other basic health care. I don't know exactly all the program,
But then there's several types of discharge. When you say do something bad, there's a general discharge, a bad conduct discharge, misconduct, and so forth. And each of these will either connect you or divorce you from a certain amount of services. And so you could come up to the VA or get online and look at enrollment and eligibility. A lot of the factors in which that have removed eligibility to services have changed over the years. And then there's groups that can help you to upgrade a discharge type, depending on what was the cause of the discharge. Thereby removing all those barriers and possibly getting you from a bad conduct discharge all the way either to a general or to an honorable discharge. But again, even there are services available to veterans irregardless of the discharge type. They just become a few less limited based on discharge.
So a key ingredient, I think, of true community engaged work is sharing power with your participants. So I'm curious to hear from you within your research, how have you tried to build in ways to share the power of, for example, decision making over the intervention, also uptake?
Yeah, thank you for that question. I think is, obviously critically important, and often under articulated as we're disseminating research, including in forums like this. So for our work in Islamic trauma healing, this applies to both the initial Somali co-development process and later implementation in Somalia with partners there, as well as the work that we've been sharing about here locally with the Afghan community. That we have learned a lot over the years, and I think we've made some mistakes, quite honestly, as we've grown. One of the things that we learned, and one of our funders of this work is an international humanitarian organization called ELRA. And ELRA has some really nice tools to facilitate partnership agreements that are multidimensional and cover not only the academic partnership piece, but also the implications for implementation and the kind of shared ownership of the work. And so we've really utilized those tools a lot. And some of the ways that has played out is that we are co-investigators on the academic side with community partners. Community is involved with the development and delivery of any dissemination product, including credited authorship where appropriate, where applicable on the academic side of things. That there's attention to the funding structure, so that, for example, with the local Afghan project that we've been talking about, the vast majority of our funding was funneled into the community and not centralized within the University of Washington as a funded organization, but actually a kind of pass through there. And so paying people for their time and trying to do so equitably. And I think, the other part of, I think your question was more on the development side, and that is a little bit more qualitative to describe, in the sense that we spent a lot of time in conversation and shared decision making about the questions that we're asking, sort of the content, the way that we're asking questions, the way that people are meant to respond to certain things, and really thinking through each one of those implications and having community ownership over those decisions. And if there were pieces where it was like, well, that's going to the data, we're not going to be able to make meaning out of that on the research side of the analysis side of things, having some conversation about that. And so So I don't know, I think it's really difficult to boil the essence of all of that down, which is I think partially how we often, all of us often get, who are doing this work often get into trouble or make missteps. But those are the ways that we've been trying to attend to it and the Islamic trauma healing project. And frankly, we have made mistakes and we try to learn from those over time.
Ditto, those key pieces, so thank you for naming that, and thank you for explicitly talking about power sharing. I think the Moved by Love project we talked about is a good example of where that's gone well for our group, of having veteran collaborators emerge and be at the, table with national leaders to make recommendations about care. We do compensate our partner for her time, the one who's continued on with us, and including when she's coming out to present at an academic conference with us. And she's a collaborator, and I think if that's the sort of dynamic and relationship that develops, that's optimal. And then she's also, sort of taking what she's learned and bringing that into her professional life as well. And that's an ideal outcome. And so I think just like what you talked about, all the different examples, just ensuring that that is a key value that you're bringing to each stage of the work from inception all the way through to what happens in downstream dissemination and implementation is so important, and doing that authentically. And as long as you have team members you're working with who are holding you accountable to that, helping you learn and see your blind spots, you will make missteps, but learning from them and doing that work collaboratively.
If that study was qualitative and coming in, their inputs, we actually spoke with them about it. So as an intervener, I would take notes from a session and in the next session would go back and say, this is the input that I believe you gave me that we wanted to deliver on high. I need you to proofread this, check it. Is this what you want me to say on your behalf? And so that I think was very powerful for the participants to say, oh, you want to make sure that you've got this right, what I'm saying, not just what you heard. And so I think that was a great level of power sharing.
Thanks so much, everyone who attended both online and here in the room. Really appreciate you spending time with us today, and thank you so much to our panelists. You want to give them a round of applause? Really amazing. Thank you so much.
One time, but I have to listen to it. When it comes to something about a good. Yeah, there's something.
I would not be surprised, though. That's on brand for me, yeah.
Did you after? Okay. Good. Great. All right. I wanna just put like one of each type of sticker. I know. I have age. I am actually not doing that work. Thanks, Emily. Oh. For example, what's your experience like?
Yeah.
There are concepts that.
Yes.
There are even new ones.
Yes.
Yeah, and so. Another language.
Size up people.
Right.
We didn't speak to here so much, but
or whatever.
Yes. So day and day. Validity is both right. A lot of conversations about what is the community that were within.
There's a sorry, yeah.
This is what the US based team is intending, and that's what the community will understand, and it's all a lot of good metaphor and
Have the same community.
And that's how it works. Most of the time, it's us, the researchers.
Yeah.
Doctors stay what we say.
Yes.
It has to be exactly what we say. We can't, we can
Yes.
ask this, we can take
Yes.
away from it. And how is-
Stop Steve.
And so the metaphor that, or the way that we talk
Thank
about
you
with
so
our,
much.
thanks, Kate.
So nice to be in.
We will always, say,
Always,
this is the recipe, add your spice. You know, everybody, you know, some people might add more spice and other people might add less.
That's why people, and that's because you look, you look at